Presenting today, Dr. Matt Misner, one of our pediatric fellows, and the podium is yours.
Thank you, John. Good morning, everyone. I'm one of the fellows here with Trinity and Faith Hospice, and I'm going to present today about good parenting. And I'd like to start out by thanking Dr. Peter Basinger, who is the physician, the palliative care inpatient physician at Peyton Manning St. Vincent's Hospital in Indy, who I spent a month with last in April. And he's the one that kind of helped me kind of cut my teeth on this topic and actually utilize it with my patients. So again, I'd like to thank him. Good morning. So let's begin. Of course, I began with no financial disclosures, as everyone would know. So I begin by starting by talking about three main objectives that I would like to accomplish today during this presentation. And that's one, to describe the attributes of a common quote unquote good parent, to note the differences between beliefs for several parent populations, and to recall three ways to use the good parenting paradigm in clinical practice. So the presentation, I'm going to begin by showing you a graph. Pamela Hines is a physician who has written quite extensively about this topic. And one of the articles that she wrote, as you can see there in the Journal of Clinical Oncology in 2005, entitled End-of-Life Care Preferences of Pediatric Patients with CARE. This graph, the reason why I put this is to show you, if you look at 1921 up to 2023, this last year, this graph was showing you the number of articles published about this topic. So if you look in from the 1920s, up to about the 70s, 80s, you see that there was basically nothing published. And then all of a sudden, you see this steep incline of interest. And of course, I think that goes parallel with the fact is that we saw an uptick in life-saving measures, with the introduction of artificial ventilation, G-tube use, and long-term care. This question of what is a good parent came to light. I would also like to mention about this study. This study was performed in two locations. First of all, it was a partnership between St. Jude's Hospital in Memphis and the Sydney Children's Hospital in Australia. This is back 2005. So you're looking at 18 years ago. And some of the points that came from, or main points from this article are the following. It allowed the parents the opportunity to express a desire to be a good parent. So this essentially was the first time that we had this kind of clone definition of what a good parent was. Now, obviously, there was discussion before that, but this is kind of when it was kind of minted. And what they did is they also stressed the importance of incorporating the affected children into the decision-making, which is also interesting because up to that point, it was pretty much parent and physician. And now they were actually looking at, well, how does the child's voice get incorporated? And this had a double effect because not only did it allow for some autonomy for the child who was receiving the treatment, but it also allowed what I would suggest is a level of comfort to the parent after the child had passed. So during their bereavement period, the parent could look back and say, hey, it wasn't just me doing this. My child also had a say. And that's something I'd like to touch upon. And that's what this kind of good parenting definition is kind of touching. So from there, let's move on and to look at, well, what actually is a good parent? And that would include questions such as, what do we know about parent perceptions? When does it form? What influences the definition? And are parents achieving the definition? Because it's not enough to just say that I'm trying to be a good parent. Are we reaching that? And when I say we're actually talking from the parent's perspective, right? So I will begin by, and Brad, if you're out there, You probably will recognize this patient. So I was with Brad at DeVos Children's back in April. And we had a wonderful 13-year-old white female who was referred to us from the pediatric oncology group to the inpatient palliative care group with a newly diagnosed diffuse intrinsic pontine glioma, also known as a DIPG. Anyone who has ever treated a child with this disorder knows how malignant these tumors are. And usually you're running from anywhere to 6 to 9 months of terminality time. I mean, basically the prognosis is pretty poor. The chief complaint at that time was weakness, headache, and a need for goals of care discussion. So this mother and father and the child were just diagnosed, and we were consulted that actually the first week. Some of the interesting things to note is that when you look at the maternal and patient understanding at that time, what do they bring to the table? You will see that mom mentioned to us, and she mentioned throughout the time we were with her, is that she knew that the child was aware of her tumor, right? But she did not see a need to mention what type of tumor, and she did not want it known or stated to the child of her time expectancy. So basically her thought is, well, maybe my daughter will think this is a benign tumor and she won't give up. But of course, we know that many of these kids already know they're sick and they already know their terminality without saying it. And what was fascinating is that this child that I'm referring to as RC actually was sent down when she went for her first palliative brain radiation. She came back mentioning to the staff that she noted the word cancer was kind of plastered all over the walls inside the. Sure. Yeah, so she wasn't fooled by what was going on. So I could understand the mom's need to kind of be protective, but the child already knew. And I think that's part of the interface that we have with the parent when we're looking at this definition of good parenting. So mom also reported that her goal was to quote unquote help her, i.e. the patient, to not lose hope. And I think that is something any parent and even us that have children, that's something that we could encourage or that we could stand for. She also said that she wanted to enroll her in the University of Michigan study. I'm not here to give my personal opinions. There is a DIPG study here at the University of Michigan. As far as I know, it's the only one right now. And her mother was like, I need her stabilized. We're going to do the palliative radiation, get her stabilized, then send her for the study. The interesting thing for me personally as a physician, at the exact same time, I was referred a 14-year-old from Riley's children down in Indy. And this child also subsequently had a DIPG at the same time. And I'm watching her in her terminal demise. She came to me about a week and a half before she passed. And I remember distinctly, I talked to her mother that first day and I said, was there anything that you can kind of look back on in this whole course? What would, that stands out? She says, if I had my druthers, I wouldn't have enrolled her in a study and I would have taken her home and spent more time. And it was just fascinating. Of course, I can't come back and tell this mom that, but it was just fascinating to be able, there's this correlation of knowledge. Now, whether or not this patient will get more benefit, I can't say.
Before we move on,
Yeah.
I just want to pick up on a point where you said that, you can't go back and tell that to this mom.
Mm-hmm.
Or you really can't divulge another patient's case. But
Perspective.
You can come back and offer options.
Right.
It sounds like mom knew what the outcome was going to be and saying, option one is kind of what you're pursuing, but there are other options on the table.
And John, I totally agree with that. Without trying to be like somebody ducking you or ducking the question. As a fellow, though, coming back onto someone else's floor would have been a little bit different for me. If this would have been like me as the attending, let's say at my own facility, I absolutely would have felt some way of trying to incorporate that if I felt like the mom and dad were receptive to it, right?
Sure. Okay, that's fun.
Yeah, you could definitely, yeah. I mean, the information was there, but I didn't want to kind of like stir the pot.
Yeah, the options on the table.
Yes. Yeah, and that's absolutely correct. So what is the relevance of the understanding of the definition of good parent? So Feutner, 2015, that's one of the articles that I have there for everyone, states that there is a deeper understanding that may help clinicians support parents who are confronting difficult decisions and guide future research. So what I would like to kind of hopefully impress upon you is this is not some just kind of archaic term thrown out, or not archaic, but some kind of guru term. You know, what is a good parent? This has actually now been researched for, 10, 20 years. And we are starting to see that, parents really do have a firm grounded understanding of who they are, what makes them that good parent, and that interface is really going to have a direct effect on the clinical pathways and decision making. And so by us understanding that, I would like to suggest that we could help kind of shape that as, with the parent as we go. And then also, what is the value of this definition? The value is derived from knowing that, again, the good parenting affects medical decisions. I refer to the first article from Hines. I had just already touched upon it. And the original definition in 2009 again states, the good parent makes informed, unselfish decisions. The red is something that I highlighted myself, in the child's best interest. Okay, so again, the good parent does X, but I would like to suggest that as long as we're also focused on what's going on with the kid, right? Because the child's receiving the treatment, provides basic food and shelter. You can read all this. The other thing I'd like to highlight is tries to prevent suffering and to protect health. I think that's very important. Child's best interest, and how do we prevent suffering while we're doing this? And also, I would like to also put in this, to know a greater being, right? I think that a spiritual component to this is very relevant. I can't speak for everyone, but that's just my personal bias. So what are some basic similar findings that they found in this study? The definition is also comfortable and referred to as supportive. So parents feel that when they share their kind of good parent beliefs with others, they feel like that they are being supported, and it's a comfort that they feel from this. Parents of children who have died of cancer report their sense of having been a good parent in life helps them to emotionally survive. So that's the other catch. It's not just surviving the experience of treatment and long-term care. It's the survival, the bereavement after, that's most important. It's also personal and duty direct. You have this relationship, parent to child. And again, it affects medical decisions because it promotes the child's health. So I would like to also suggest that parental belief systems start with the perception of self as parent. Okay, so you first have to know you're a parent, and then you see that this good parent understanding, 70% on this study reported that this understanding started before the child was born. 20% reported finding it after a serious diagnosis. So I guess what the study was suggesting, which makes sense, is the parents already kind of thought that they knew what a good parent really was. However, 67% of those same parents noted that their definition changed over time. And so that's relevant. 2/3 of them almost are saying that there is space for us to interface and maybe give redirection. We saw the study mention also that there was a noted increased self-compassion, increased burden sharing, increased emphasis on meaning making, and decreased emphasis on knowledge. And that's something we'll talk about. So you're seeing kind of a change from the first onset of diagnosis. The real push, understandably, is I need the knowledge. I need all of this information to help save my child. And then you start seeing over time, maybe it's more important that we just spend time with the child. So what are some of the influences of good parent beliefs? There's a list on there, as you can see. 43% awareness of prognosis will influence changes in the child's health, spiritual considerations. And then a big one is clinician behaviors, 18%. So that doesn't sound too high. That's 20, it's about 1/5, but there clearly was association between staff and interface with the parents. And so Weaver in 2021 reaffirmed this by saying the definition is very much affected by the interpersonal interactions with the ill child's care team. So we do, in fact, have some say in how this process unfolds. At what level? That's up for debate. Also, the feeling of achieving good parent status. So how do you know you've achieved it? We know that the parents noted that this sense increased with the child's age during the duration of illness, and a feeling of having been an advocate. So if I advocated for my child, that helped inspire this good parent definition. Also, some parents reported their achievement was based on what symptoms their child were experiencing. So this graph kind of nicely kind of shows you kind of a breakdown into what parents as they were studied, and basically the research shows that the achieving of one's good parent definition came out kind of the following. You see that half of the parents noted that sometimes they felt at the terminal end that they had met this status. Always was only about 1/5, and rarely did they not meet. So most of these parents were able to walk off with a sense of being a good parent, but only 50% was sometimes. And of that group, the studies noted that they were more likely parents to report sadness, exhaustion, and being overwhelmed, whereas the often and always groups were more likely to reflect on imperfection and grace. So there was a slight correlation between if you felt like you truly achieved good parenthood, you kind of had this sense that you had met your end goal. Whereas if you were sitting kind of in kind of the middle at sometimes, there was a sense of exhaustion. I really didn't kind of finish the line. Yeah.
So we just related to this in the previous slide, do I interpret that the parents sometimes reflected on their role as being a good parent based on the symptomatology and the effectiveness of symptom control?
Right.
Interesting. Okay. I want to make sure I caught that correctly.
Yeah. Did everyone get that? Okay. So let's revisit the case with RC. Again, mom reports her goal of helping her to remain strong and to get the child to the University of Michigan trial. She acknowledges the fact that the patient is suffering. Mom asks about home hospice and trepidatiously asks about prognosis. And she notes her perception is that the patient, will only live for months, but more time would be worth it. I would also like to suggest the following, that mom's definition may play emphasis on advocacy, that mom may be early in her good parent definition, noting the fact that she was more focused at this time on knowing and interventions. And her misperception of prognosis, or possible misperception, may have incorrectly contributed to her current good parent beliefs. And lastly, mom may struggle to feel that she's a good parent since she perceives great suffering for RC. So in summary, I would like to suggest that the definition of good parent, it's comfortable and supportive, it's personal and duty directed, it affects medical decision-making, it's informed by medical encounters, beliefs start with perception of self as parent first, and then changes over time. It's influenced by many factors, and some parents, especially with time, feel that they achieve good parenthood, and this in turn helped them to interpret a more tolerable outcome. So now we proceed to our second objective, and that's beliefs, understanding the beliefs of different parent populations. So I would like to begin with a quote from Jodi Picoult she wrote a book called House Rules, which was a research study that looked at the pressures and challenges of families when they're facing a child with Asperger's and autism. And what she said is the very fact that you worry about being a good parent means that you're already won. Meaning, and I like to put that Latin quote up there, cogito ergo sum. Basically, I think and therefore I am, right? So just for the fact is we're thinking this way is actually putting us into this definition. So this slide, and I'm giving credit again back to Dr. Basinger, because he helped he let me borrow this. This slide, he basically, what he did is he took a study, and that study was from Weaver in October and Feutner, entitled Good Parent Beliefs, Research Concept and Clinical Practice back in 2023. And basically what they did in this study is they noted that there were characteristics, themes, and subgroupings of these parents. So they weren't just basically coming up with their own idea of what a good parent was. They were all kind of, not to pigeonhole them, but they were all kind of meeting a certain understanding together. And you can see on the left, it's everything from advocacy and championing and supporting, obtaining was considered a good parent, down to considering quality of life, implications of med treatments. And then within these themes, you had basic subgroupings, and that included making informed, unselfish decisions down to promoting the child's health. And then lastly, the four major components of all of this that they kind of extrapolated from this data was that what was the main emphasis for the parents as a whole was that the child felt love, that the child's health was upheld, that they were advocating and there was information received and given, and that there was an understanding of spiritual well-being. So I would like to go now and present a second case. Two-way, I would refer, this child's name is RK. She is a private palliative care patient of mine in Mishawaka. This is a 3-year-old with Dravet syndrome. For those who may not know, is the first case that I'd ever have. It is a rare genetic disorder with basically it's intractable seizure disorder is what it is. It's devastating. And this child came to me, and she's recently received a vagus nerve stimulator for worsening intractable seizures. Her care team, the specialists and main providers at Rush Hospital in Chicago, has had multiple conversations with mom and dad expressing the worry of disease progression despite these efforts. Mom speaks of enabling joyful life experiences and her increasing burden of symptoms of the patient. And the parents currently are expressing the need to move to Denver in the fall to be with the other kids with this disorder. I am selfishly hoping they wouldn't, because this family is wonderful. But and the same with the physician, the specialist at Chicago, we would love to keep them, because we have this sense that basically we've gone as far as we can. But if the parents think that this is a good parent, is to give that child that last hope or that last try, who am I to stop it? So they will be moving in July. So some of the things I would like to mention, go ahead.
Is Denver kind of
It's the Mecca.
That's where patients with this thing.
Yeah, and what's interesting is there's two major specialists, and I have talked to them both on the phone. The physician that started actually is out of the University of Oklahoma. He's now at St. Jude's in their neurology department. He is the one that actually kind of came up with the paradigm treatment for Dravet. And his partner, who is now at Rush, basically this child has been under the care of both of these gurus. I mean, really excellent doctors. But the real hub where you get all the number is in Denver. You get community. Community. So that's what it is, and it's set up. There's like literally, like we're saying, there are people that they live in neighborhoods together, and it's like a Dravet world, I guess. Yeah. So some of the things I'd like to refer back to the previous slide where I had mentioned some of the things that do influence the definition. This study had mentioned that they did not find any evidence to suggest that socioeconomic status, race, the child's clinical status, the age of the parent, religion, diagnosis, or treatment decision actually had an effect on what the parents actually thought, which is kind of congruent with, or not congruent with what was originally stated. This is a graph that I would like to present. This is in Futer's article that I have here on the table for you. It's from the JAMA Pediatrics in 2015. And so what's fascinating about this is that if you look, this was a separate study. And what they noted in this study is that there were 12 different groupings of understandings of what parental good parenting looked like. So this is kind of comparison study to the one I had showed you that had more of the kind of the subtitle, the subgroupings. And what was fascinating is that the four main belief groups that they extrapolated kind of compared to the first, and that is child feels loved, child's health, advocacy, spiritual well-being. So this is basically those understandings are kind of came out in like 4 or 5 years of separation in 2 different group settings. So if you look at those separate groups that I had mentioned, if you looked at the group where the parents were more interested per se, their definitions are more aligned with the child's health, you will see that there was more financial difficulties, but the real interesting thing is that it was more likely to have a newer diagnosis, which makes sense. When the child was first diagnosed, it would make sense that the parent would be more interested in what the health was. In the subgrouping labeled loved, child feels loved, the parents were more interested in shared medical decision-making. They were also less likely to delegate decision-making to the physician. Then you go into the spiritual well-being subgroup, and they were least likely prefer making decisions, and they were least likely also to be less depressed and they were more hopeful. So there's this kind of this give and take, and what your emphasis is on, and kind of what the parent was basically demonstrating as far as their own personal beliefs and health. So what did we learn when you look at maybe the difference between a father and a mother and with all of this? Now, I don't want to try to sit here and stereotype people, but this study said that the fathers tended to be more concerned about informed medical decision making, whereas the mothers tended to focus more on the child's health and putting the child's needs above their own. They also noted that during the study, what they did is they gave the families an option to enter a phase 1 trial, or to actually to sign off on a do not attempt resuscitation, and then basically not to come on board with the trial. And what they noted was that the parents who chose the trial option reported that it was their duty to obtain medical facts and to prolong life, whereas the parents who chose the DNR option reported that the emphasis was more about optimizing quality of life and honoring the child's wishes. So the other thing that I would like to mention that this study brought out, and I think this is where the meat of all of this is there a difference in this definition when you look at the beginning phase and then you look at the progression of the time that the parent and child are doing all of this? And there is a more emphasis on the relationship with the child as time goes on. So you see more emphasis again on the quality experiences, the memory making. We move from the understanding of perfection and to a more of an understanding of play, laughter, love. We move from an individualistic, autonomous approach to more of a sharing burden. There was more increased grace towards oneself. And they moved also, one study also mentioned that there was a paradigm shift from a knowledge base to more of a love base. Before I go to, I also wanted to, in that study, there was a quote that one mother gave, and this is what she said. She said, when our daughter, was very little, I thought being a good parent for her meant being 100% committed to knowing absolutely everything about her medical condition. I read journal articles, I stayed up late at night, etc. Over time, I realized that I cannot sustain that kind of focus and continue to build good relationship with her, her siblings, my spouse, or pretty much everyone else. So I began focusing more on sharing experiences with her and less on the actual treatment. So I'm going to shift now to a second case that kind of relates. This is a child I'll refer to as ZN. This is also a private palliative care patient of mine in Mishawaka. This child is an 8-year-old with Lennox-Gastaut syndrome. This is another genetic disorder with intractable seizures. This child unfortunately had a devastating beginning. He was exposed. He basically had fetal alcohol syndrome exposure, and he was received shaken baby syndrome. This child was abused first week of life and was just devastating. The parents, who I consider the parents, the adopted parents, unfortunately the father went to jail. He has intractable seizures, recurrent hospitalizations. Mom was once responsive when she talked to me initially. She said to all treatments, but now she focuses on concerns related to his suffering, quality of life, likelihood of ever, quote, being normal has kind of subsided for her. The father is present, yet he usually responds the same way. He says, all the control is what she wants to do. The dad's kind of hands off. And if you were to look at how they reflect, you would say, if we had known what that's what she literally said, had endured, meaning his whole treatment course, we would have focused on comfort from day one. But now what do we do? And there's where the definition of good parenting kind of steps forefront. And this is kind of where I or any physician, nurse practitioner, or other caregiver can actually help that family kind of redirect what they're thinking and treatment options are. Yeah.
I mean, I know given the topic, it's not a good issue, but I'm assuming both of these cases are terminal.
They are eventually terminal, yes. Right now, both of these children are stable, but like for instance, the child with the DeVay syndrome, she is basically her tone is now poor, and she's basically on crawl. When I first got her, she was able to do some kind of holding on, and she would walk on the table, and now she's just basically flat. So it is, yes.
So they have to be fed.
They're both G2 fed. Yeah. So they can take PO, but they've failed multiple swallow studies. So to do that, set them up for aspiration. You know how it goes, right? So in summary, I would like to say that early compared to later, as far as the process, you can see this paradigm shift from knowledge to love, perfection to grace, and autonomy to sharing your burden. Fathers were more interested or thought of medical decision making as most important. Mothers thought that child's health was most important. And please recognize the fact that there are themes and subgroups to this topic. Again, it's not just one fits all.
I think just pause there for a moment to reflect on that first bullet. I think that's hugely important. And not just for this somewhat narrow topic of thinking about, what constitutes good parenting. I would submit that bullet is hugely important to all of the work that all of us are doing in hospice. And then you could extend that to say, if you can objectify those three things with your patients. So Mike is as a burgeoning family medicine resident, you take that into your residency with all your patients, you're going to thrive as a physician when you can begin to distinguish that. Because I think that we as physicians have a great tendency to lean to the left side of that, knowledge, perfection, autonomy. And so independent of what we're talking about in terms of parenting, and in fact, one of the things I was thinking about was when you finish up this fellowship program and you start getting independence, well, you're already independent, but what you need to do is to take this and translate these definitions of what constitutes a definition of good parenting to what constitutes a definition of good doctoring. Because I can see some parallels there in terms of where is our interest. And I think we lean toward the left side of that, and we need to balance that. Anyway.
I think that's a really good point. The other thing I would like to mention is that it's something I think you were I'm gonna kind of jump on what you were saying and say, this is applicable, in my opinion, to all of us, like you mentioned. This is not just about I mean, that's kind of pigeonholing the whole topic, right? A child and a critically ill child. This could be a regular child or an adult, right? This could be a child in a clinical office that has an upper respiratory infection. The parent is going to have their good parenting understanding when you come in there, and their understanding of, is it more important about the knowledge that I'm giving or the care that I'm showing, right? And when we're dealing with, like, especially here at Trilling Woods, I'd like to suggest, you know, that it's often the daughter and the son who are now kind of making that parent decision. So it's basically the same thing turned backwards.
Exactly.
And they have their understanding of what is a good son, what's a good daughter, and we need to know that, and then show them that kind of love and respect. So I'm going to move on now to the third objective. Am I still good on time?
We're good.
Okay. Because I have to what, 8:15?
8:30.
Okay. So let's recall 3 ways to use the good parenting paradigm in clinical practice. Oh, nope. So why? So the real thing that I would like to mention now is the so what of all this, right? Why does it matter? Why does this topic matter for our day-to-day work? And you had just briefly touched that, right? Recall that good parent beliefs frame parental perspective on best interest. They shape parental role priorities, and they guide medical decision-making. So Porter just mentioned a physician in one of the pediatric critical care conferences noted the following. She said that in her study of looking at the topic of good parenting, you are more likely to have achieved this feeling of good parenthood if you've chosen to do less. That's what her study had mentioned. And the other take-home point is that she wanted it noted that only 32% of 1/3 of all, this was actually a study that was looked at in a PICU setting. Only 1/3 of the parents were ever told that they were a good parent by the staff. So there's definitely room to kind of touch upon that.
Yeah, and the parallel, because since you brought this up before, is how often do we acknowledge adult children of patients with, you know, Alzheimer's and other sorts of dementia or terminal illnesses, that they, as children, are doing a great job in terms of caring for and making decisions for.
And making sacrifices, right? They're sitting there in the fire on a daily basis, and we kind of look at them for 5 minutes. So I think it's really important that we go in there and acknowledge that. I personally, I think it is relevant, right? Please, you know, make note that this good parent paradigm is a good segue for the following. It helps to acknowledge emotion. It helps to build trust. That in turn helps us shift towards goals of care and allows then the possibility of personalized recommendations by the care team. So my last case is a child that I'll refer to as GL. This was a private hospice patient that I have in Mishawaka, who was subsequently, unfortunately, passed just recently. This baby came to me as a 1-day-old, former 36-week-old with trisomy 13, acute respiratory failure, shortness of breath, and need for intubation, and had multiple cardiac defects. And there were basically several statements that were made or that I had brought in, and that the mom or the parent had brought to the conversation. And I would kind of like to extrapolate further. And there's the 4 right there. So for instance, mom shared her feelings of guilt, wondering if she should have done something different to help the patient's course. So that would tie into the first component of this paradigm, and that's acknowledging the emotion, right? And one of the things that that Dr. Basinger taught me, I think this is wonderful, is this acronym of NURSES, N-U-R-S-E-S. I mean, nowadays it seems like we're in this world of acronyms, right? But this really does work. I mean, it's naming, understanding, respect, support, explore, and silence. And so what you can do is you can kind of bring this paradigm into any kind of conversation that you have with a patient. And it helps you kind of understand where they are emotionally and how to interface with them. So for instance, if you look at this, I, in fact, could, my way, and again, these are my own statements. Every one of us is going to have our own kind of shtick and approach to this. But the naming for me is like, I can tell you're a good mother to GL by the way you're thinking through how you can help. Okay, so I mean, I acknowledged how the mother felt about what she wanted to do. Then the understanding, like when you mentioned that you understand that she knows the situation and that she has kind of a final decision that she's thinking of. You're respecting her through this process by listening, right? And you might say something like, I'm so thankful that GL has you as her mom. Something that's simple, right? And then you go all the way down, and then I would suggest that the last piece is just as important than any of it, and that's just the overall silence. You name it, you understand, you respect, and then you just kind of let the parents sit in it. And then you kind of open up that next gateway to conversation, right?
They teach this pretty heavily at Michigan State's medical school.
Oh, do they?
Or they used to,
Oh. So you've seen this,
Yeah.
Michael? Okay, because I've never saw this until.
There was a gentleman, I don't know if he's still faculty, I think his name is Dr. Smith, but he wrote this book about
that.
in the URS. Yeah, I don't think he had the EMS at the end, but I like the EMS at the end. But yeah.
It's a part of our like clinical exams. There's 1,000 different check boxes that they can grade us on, and nursing is one of those.
So I don't want to put you on a wall, but have you ever utilized it?
Yeah.
Huh?
Yeah, and I think the thing with acronyms is it's unrealistic to like sit there and like go through
Yeah.
it in your head, but it creates a roadmap to do it.
At
in
least
your
to
own
think
way.
about it,
Yeah.
right?
Yeah.
That, wait a minute, I'm not out here without a or,
Yeah, and sometimes it's probably important to kind of be genuine. You can kind of like say some rote things that kind of sound like they're kind of forced, but obviously they're gonna,
it's,
be very, very,
again, it's a segue, right?
yeah, be very happy to hear things like this, yeah.
As opposed to nothing, right?
Yeah, exactly. But I like the EMES. I've not seen that.
So moving now from the emotion part, I would like to suggest then we could open up the possibility of building trust. So the mother during this conversation denied the situation being anything like their life experience, and that would be her and her husband, or reminding them of a similar event. And so I would open up this with possible statements like, I've met many good parents, some of which find this to be significant suffering for their child, and others do not. What do you think? Right? And again, allowing the parent to present more of their understanding and building that trust while we're conversing, as opposed to me just hammering, right? Then, once we kind of feel, and again, this doesn't, I'm not trying to suggest too, this is one conversation. This is over. This could be like weeks, months, whatever time you have. But the eventual goal is that we're possibly able then to kind of shift towards goals of care. So mom and dad, as I mentioned before, do perceive suffering for GL, particularly in the injustice of carrying heavy medical burden. Mom shared her worry that he would suffer severe debility. That's what she did not want. So how about a statement like, I hear you're worried about what he's enduring, and how do you think you could be a good parent to GL right now? Or knowing what you know now as his parents, what would be a successful outcome for him, right? And then lastly, the finalization would be hopefully to kind of interject some personalized recommendations, right? After all of this has kind of been hashed out. again, I started with, I acknowledged their hopes and worries for GL, and recommended that we focus on comfort, memory making, and then move towards compassionate extubation, because that was really the question at hand. This child was in a inpatient setting. They initially intubated, and that's got to be one of the hardest things a parent will ever have to make a decision on, right? And so some of the statements that kind of came to my mind is, given what you've told me about your value for GL as his parents, I recommend X. So again, it's not, I want this, it's what you value. I could say this as a recommendation. I appreciate you advocating for GL. Could I make a recommendation, right? Asking for a slight permission. And then lastly, I can tell you are good parents for GL, knowing that you've done everything possible for him, acknowledging again that they haven't just quit, right? Is quite important to you. Could we talk to the neonatologist together about what options remain? So that also, I think, is important, because you're also opening up that conversation to the specialist who's also involved. So it doesn't make it look like I'm necessarily pushing an agenda, right? The last thing that I would like to mention is briefly is what was referred to Weaver in the Journal of Palliative Medicine in 2021, just recently, identifying as a good parent. Also kind of framed this understanding of paradigm, the structure, into 4 frames of identity. She listed personal, enacted, relational, and communal. And how she kind of defined this is the first identity that a parent has when they're looking at healthcare and they're looking at this good parent kind of definition is they want to know if they are a good parent from the start. Like, what is it that makes me a good parent? So how does the parent define themselves? Then the parent identifies him or herself kind of in an active way, where the team actually helps the parent feel like that their feelings are being acknowledged and that they're actually a part of the decision making. It's not just me. Now I'm incorporated. Then the relational piece is where we have gone further and we've kind of included a spouse, grandmother, or whoever. So we've extended that out. And then the last is the community as a whole. How do we as society make this parent feel like that they are a good parent? And one of the ways that I was thinking about this as far as achieving that or helping achieving that would be like a provision for family leave policy that allows flexible work hours so a parent can work and still be part of the patient's care, right? That's how we as a society also helps with this identity issue. So this article, the pediatrics, I put it on 2 ways. First of all, John Lantos, I actually got to study with him at, he's an incredible bioethicist. And I received this years ago, and I thought that this kind of tied in. It was in the Pediatrics Journal back in 2020. And what they noted from this study was basically, you could just summarize it like this. You got a group of 3 neonatologists looking at parents, and they asked them, what is it about good parenting that we're interfacing with you? What helps us help you be that good parent? And they said 3 things over and over. 1, I'm a good parent. I need to hear that, well, first of all, I am the parent. Because a lot of times in the inpatient setting, they're kind of on the outside, right? We get to put on a gown, touch the little infant, right? The preemie, and the mom and dad are sitting in the chair hoping, right? But I am the parent. Secondly, that I'm not a bad parent, because there's feelings of guilt we don't even consider when the child's sitting over there and we can't touch or interface. Does that make me a bad parent, right? You do everything and I do nothing. And then the antithesis of that is I am a good parent. So that's the thing I would like to suggest, that we acknowledge our families as the parent, that they're not bad and that they're good. So again, the 3 objectives that I just went over include the following. First of all, looking at the attributes of good definitions, or the good parenting definitions, remembering that's comfortable and supportive, all the way down to remembering that with time, that definition will change and that we can help along that process. Two, that there are differences within certain parent populations. That this is not just some term that's thrown out there. It's been studied, it's been researched, and that parents kind of have a joint understanding that we're moving from an early understanding to a later understanding with time. So therefore, again, it's important that we interact with this topic. And lastly, again, the themes and subgroups do exist. And then the final objective, again, the paradigm, that when we're going through this process, we can look at it in terms of acknowledging the emotion, building trust with the family, shifting the goals of care as, as we're going along, and then actually incorporating recommendations. And then always keeping in mind that parents need to hear that they are the parent, they're not a bad parent, and they are in fact good parents. These are my references, and thank you. Oh, and that, by the way, is Rackland House. That's our equivalent to Trillium Woods. So that's where I work, and those are my true children. This kid up on the top actually did a play with my daughter Violet. He's getting credit, but he's not. Because I didn't have an individualized picture. So that's my daughter Lydia down at the left. She's turning 15 this week. Violet's on top, and then Ty's down on the right.
But wait a minute. You don't have another individual picture of Violet?
I do.
What type of parent are you?
I'm a bad parent. No, I was thinking about, I did not, I wanted to put that in because she did her play last week. But they only sent me like joint. So I'm sure my wife has.
Is that in Mishawaka, the house that you?
Yes, so.
Palliative care.
Yeah, so I work this Center for Hospice, and the Rackland House is kind of like, and John's been there, it's equivalent, something like Trillium Woods, but we build it actually right on the St. Joe's River. It's, in my opinion, it's amazing. All the rooms are individualized, and they do open up like here, but you're actually open up to a porch that looks at the river. Yeah, it's nice. And we have a sister facility. So that one's 12 beds, and then we have a sister out in Elkhart, but that one's only 7. But that kind of meets that end of the state. So anyway.
All right, so we'll open it for questions, but I had just a couple of things that I wanted to I'll take advantage of my position here and throw in my comments first. This is really, I thought, very, very useful and very interesting. And so thanks for presenting that. You had a couple of references from Chris Buechner, and I had the opportunity to share a podium with him about a dozen years ago, and it was a pediatric conference, and we were chatting between lectures, and we were talking about the concept of hope. And it was Chris that gave me this phrase that I use all the time now. I think it's relevant here. We were talking about hope, and when all of us have gotten this comment from family members, from other physicians, to say, well, I don't want to take their hope away, as an excuse for doing things that seem to be not in the patient's best interest. Chris is the comment says, well, what hope is it that you're talking about? And that really struck me, and I've used that time and time again since then. So it's to see his name popped up there. I haven't thought about it in a long time. To see his name popped up there is very useful.
Would you mind elaborating just a little bit? So you offer that up to the parents.
Yeah. Well, this is not necessarily isolated to parents, but when someone will say, well, I know I don't want to refer him to hospice. I don't want him taken to palliative because I don't want to take his hope away. My question is then, well, what hope is it that you're talking about?
Yeah.
And then inferring that going on a non-curative track is
Yes, exactly.
but that's not necessarily.
And so it gives you an opportunity to reframe the hope and to bring the reality in, because a lot of times what they want is something that is impossible to achieve. And then, I was thinking your first case there, about 20 years ago, I was asked to see a 17-year-old kid at home for pain management. He had an osteosarcoma, and they had taken off his leg in pieces, and finally ended up with a hip disarticulation. He was having severe pain. So I went up to the house, and I come in, and the parents greeted me at the door. They're a little quiet. Thank you so much for coming. He really needs your help. He's in such pain. But we have one request. I said, what's that? Please don't tell him that he's dying, because it would destroy him. He's been a fighter. He just really wants to live, and to know that he's dying would just, it would destroy him. And we just can't have that happen. And so I paused for a little bit and I said, I'm not in the habit of lying to my patients. I'm here to manage his pain. I'd be happy to address his pain. I will not present prognosis as a reason for my being there, and I will not initiate that conversation. But if he asks me about it, I'm going to be truthful with him. And I said, and he's in the back room, so I said, I'd like to see him alone. So I went back there and I went in the room. He's 17. I felt it, and he needed a voice there. First thing he says to me, he says, thanks for being here. I got terrible pain. I'm glad you're going to help me with that. But I got one request. Please don't tell my parents that I'm dying. It would destroy. I mean, the language was almost identical. It would destroy. Somehow they think I don't know what's going on. I think I'm going to live forever, but I know what's going on. I know I'm dying. So that made it a very easy conversation. Called the parents in. Okay, you guys got this huge barrier, but you both know what's going on. So let's. Quite frankly, the pain was the easy thing. Right. So that aspect of that, again, gets to this issue of hope, and gets this issue of knowledge versus versus compassion, all that other sort of things. So anyway, okay, I'm going to just see what kind of questions or comments do you all have from that this morning.
Again, I think what's relevant for me is I don't see this just in line with pediatrics. This is for all our patients.
This is about parents in general.
Yeah.
Too. I mean, not just in diet and care and diagnosis. That's kind of that bullet that John had mentioned with the, I can't remember what it was, like I don't know, like perfection above or perfection this and all that. Is that something that you saw in your reading, or did you kind of feel that in your heart?
I felt
and so you through your career figured that out, which is pretty.
That's kind of how I see it. I don't always achieve that. I think we're always trying to better, but I see how parents and people and me in general, that's I think what we're trying to achieve. And it makes sense that we want to do everything up front, right? Especially when you have a child who's suffering. But I think there's so much more to gain when you move out of that. Unless the child is absolutely curable, right? And even then, though, you still have to deal with, well, then what's a good parent with side effects, right? I mean, it never ends for us. Whether or not a child dies or not, whether or not a child has an upper respiratory cold and goes home and I never see him again. But I still think that achieving some understanding of love and compassion is what we really should be doing. Because in the large scheme of things, I mean, we given an amoxicillin dose, what was that? I mean, what really? And that's why I personally, not to heart, I mean, kind of pat myself, but that's what I get really out of mission work too. It's not about going over to Katie and giving out amoxicillin, right? It's about just acknowledging somebody's suffering, just being in presence. So anyway.
Well, thanks.
Thanks.
Can I make one comment? I apologize. This is Brad. I apologize. I'm driving and went through a complete dead zone, so I lost the last couple of minutes. So I apologize. But just wanted to chime in super briefly. I promise, Matt. I thought this was a great discussion. I appreciate you bringing this topic up. The one thing I'll say is I think in my practice, and maybe it was discussed when I dropped off the call, I think sometimes I'm a little more even bolder as things are transitioning for a child around this concept of what does it mean to love your child and be a good parent, and absolutely acknowledging you are a great parent, even if I don't necessarily agree with the decisions they're making. Obviously, that's the art of what we all do, that I still will tell them that. And I've told many, many families over the years, that sometimes loving your child means making the most difficult decision you can. Like the worst decision you can imagine may be the most loving. I've used that dozens of times probably as things shift, so that they know you have been a good parent and you still are a good parent, even if you make a different choice as things progress. That's all I'll say, but thank you for the discussion.
Thanks, Ben. Great point.